Hello, let's talk about sickle cell disease. An 18-year-old African-American male presents to you. You're playing a primary care physician seeking to transfer care. He has 3 to 4 episodes per year of musculoskeletal pain, self-controlled with NSAIDs, and currently he has an ulcer on his ankle. Now, this is a very common physical exam finding in people afflicted with sickle cell disease because not only does sickle cell disease give you an anemia, it also creates small vaso-occlusions leading to tissue ischemia, hence the ulcer. So because you're suspecting an anemia, you work up the blood, you find a low red count in hemoglobin, you find an elevated reticulocyte count confirming the anemia. You look at the mean corpuscular volume, it's 96. This is a normocytic anemia. So you order hemoglobin electrophoresis because everything else fits, and you confirm the diagnosis of sickle cell disease. Now, sickle cell is caused by a point mutation in beta globin that promotes the polymerization of deoxygenated hemoglobin, leading to red cell distortion and hemolysis as inclusion bodies build up within red cells. But you don't just get an anemia. These red cells like to stick together and clump, and these clumps of red cells can obstruct capillary beds, which then in turn are going to obstruct small arterioles, and that'll cause some local ischemia wherever the obstruction occurs. And so that's why this is called sickle cell disease, because when these red cells stick together, they're shaped like sickles on microscopy. Now, sickle cell disease is mostly present in the Black population. It's an autosomal recessive trait, and it does not appear until 6 months into a person's life. Why not? Because before 6 months, you're making fetal hemoglobin, which does not incorporate the beta globin protein. So if you've got a mutation in your beta globin causing it to polymerize, you just don't have a lot of beta globin until that 6 months point of time. And following that shift from fetal hemoglobin to adult hemoglobin A, that's when sickle cell starts presenting. And in children, the most common presentation of sickle cell disease is dactylitis, or inflammation of the digits of the hands and feet. So why would that be the very first part of the body affected by sickle cell? Well, it's a vaso-occlusive disease. Where are the smallest arteries in your body? Some of the smallest arteries in your body are in your fingertips. You go down, 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 and they get smaller and smaller and smaller and smaller as you approach the digital arteries. So that's why the capillary beds in your fingers have a predilection to get these clots of sickled cells within them. So it's autosomal recessive, meaning you need both genes mutated to have the disease. If you only have one mutated gene, you're asymptomatic, largely. And we call this sickle cell trait, not sickle cell disease. It means that you're able to pass it down. And I grew up in Tuscaloosa, Alabama, and that's a city that has a pretty large Black population. I remember seeing a whole lot of signs all over the place. This is one of my first healthcare memories when I was about 6 or 7 years old, talking about get your sickle cell screening now. And this was about at the turn of the century, when our genetic technologies, diagnostic technologies were really starting to get pushed into the primary care office, and we were capable of screening patients for these genetic diseases. So screening is really good, not just for identifying disease, but the trait as well. And so there are a couple of clinical symptoms that ought to make you suspicious enough to order that screen. We'll get to those in a bit. So again, if you're heterozygous, that's sickle cell trait. You're homozygous, that's sickle cell disease. And sickle cell disease is around today because, much like the thalassemias, it is protective against malaria. That's Plasmodium, Falciparum, Vivax, ovale, right? So why is sickle cell disease protective against malaria and beta thalassemia, alpha thalassemia too, for that matter? The answer to that is because when you have one of these hemoglobinopathies, your red blood cells have a shorter lifespan in general. And Plasmodium is an obligate intracellular species. What's the cell that it occupies? The red blood cell. So if the red blood cells in your body are sticking around for 2 or 3 or 4 weeks as opposed to 2 or 3 or 4 months, then malaria just doesn't have the time to replicate. There's your protection. Sickle cell does have the tendency to stack into polymers. Here's a great example. You see just 5 or 6 sickle cells starting to aggregate right there in the middle of that slide. And this stacking is what leads to the characteristic vaso-occlusion that you see in sickle cell disease. What organ is this? That's the spleen. It's a reticuloendothelial organ with red pulp and white pulp, and you can even see that grossly on microscopy. But most notably, this spleen is infarcted. That's tissue necrosis due to occlusion preventing oxygenation. And it's infarcted because in this patient's case, a big old glob of sickle cells, way bigger than what you see on this slide, got stuck in a few arteries. Here's a CT scan. What's this? Liver? Nope. Wrong side of the body. That's the spleen. That's a very big spleen. So in acute splenic crisis associated with sickle cell, you're going to see a big old spleen. Unlike spherocytosis, splenomegaly is not a common presentation of sickle cell. In spherocytosis, you get splenomegaly every single time. Every patient with spherocytosis, that's how you diagnose it. Palpable splenomegaly, scleral icterus, maybe gallstone disease. But with sickle cell, the spleen gets along just fine unless it's really acutely affected by an occlusion of a large artery. And that's going to lead to the big spleen. Here's what that looks like histologically. You can see red blood cells are just stuck in this boy. And normally the spleen's a sinusoid organ, meaning blood cells kind of just fall in line and go single file through the cords of Billroth. They're about 2 microns in diameter. But if there's a big old group of sickle cells that just won't move, then that's going to blow the spleen up. There's your infarction. And again, that's an acute episode. This is also an acute episode. Dactylitis, again, the most common presenting symptom of sickle cell disease. And this is the disease that you can get even in the first year of life. Again, that 6-month mark when you stop making fetal hemoglobin and you start relying upon hemoglobin A, that's 98% of your blood, which is 2 alpha chains and 2 beta globins. Because sickle cell is a beta globin mutation, here's your presentation after 6 months of age. And this can happen to the feet too. You really need to be able to recognize, because it could be unilateral, to compare hands. Ask, has this ever happened before? Very, very good tool in your belt for getting that sickle cell diagnosis. Here's a distal leg ulcer that the patient in the case we talked about presented with. And the reason why the malleolus is typically affected in sickle cell is because the skin is very thin overlying those bones of the ankle joint. And the thinner skin is, the less blood supply it has, so the easier it is to occlude. That's why ankle ulcers are the most common side of the body to be affected by vaso-occlusion in sickle cell. So you see one of these, what do? Well, you don't just call somebody else, you're the doctor. So if you're the guy who's got to deal with this, or gal, then you clean the wound as best as you can. You get all the fibrin off there, you get all the scabbing off there, and you want to get down to fresh, healthy tissue. So then you keep it as clean as possible, and you instruct your patient to do the same. When you check up on them next, you're looking for granulation tissue. Remember, that's pink, like bubblegum pink. And you see granulation tissue, and your next thought is, okay, This sucker has started to heal. We've done our job. We're going to leave it alone and keep it as clean and fresh as possible until it's covered up with granulation tissue. That's how you're going to manage this leg ulcer. So those are some of the predominant presentations, your first look at sickle cell disease. Now, heterozygotes with sickle cell trait, why don't they get these vaso-occlusive crises? It's because they just don't have enough mutated hemoglobin in their red cells to promote sickling. At about 60% mutated hemoglobin concentration, red blood cells start to sickle. And the SDL says that in heterozygotes, only about 40% of the hemoglobin in a red blood cell is sickled, and the rest is normal hemoglobin A. So it's just a numbers game, a concentration game there. So with sickle cell trait, moral of the story is you don't see any symptoms, except in one case of chronic hypoxia in a certain anatomical region. And that would be the peritubular capillaries of the kidney, which have a very low oxygen tension. Therefore, even patients that are heterozygous with sickle cell trait, they can get occlusion and sickling as blood moves into the medulla of the kidney. And this would present as a microscopic hematuria. So if you have a black patient and they're cool, they're fine, no other symptoms, but you get urinalysis for whatever reason and they've got trace red blood cells, you ought to be thinking, have you ever been worked up for sickle cell trait? And if they haven't, go ahead and do it because it's something that they and you would love to know. Now, getting more into the specifics of the mutation, it's a E6V single nucleotide polymorphism in which you replace glutamate with valine, and valine is nonpolar, non-charged. Got that? So what holds sickled red blood cells together, they're stuck together by a force. What is it that holds them together? The answer to that is hydrostatic interactions. And really, I said something holds the red blood cells together, but it's more like something sticks hemoglobin together within these red blood cells. One hemoglobin and another hemoglobin, when they bump into each other, they stay stuck. And the reason for that is because this valine gets caught in the valine of the other sickle cell disease, and they form a weak hydrophobic interactions. You know, hydrophobic, I don't like water. There's water outside. I don't want to go out today. You know, it's like, won't even leave the house if it's raining. So that's valine, and that's why hemoglobin aggregates and polymerizes inside red cells. And when it polymerizes enough, it forms strands that are directly responsible for the sickled shape of the red blood cell. What else do I have on this page? Again, infants don't become symptomatic until 5 or 6 months of age. Fetal hemoglobin drops. That doesn't have any beta globin in it. That's got gamma. You got 2 alphas and 2 gammas, and that's fetal hemoglobin. So when fetal hemoglobin goes away, beta globin comes out to play, and that's when you can see the dactylitis. Now, we also mentioned on this page hemoglobin C, which is another mutant beta globin. It has a lysine residue instead of glutamic acid at position 6. So instead of a valine mutation, it's a lysine mutation. Now, lysine is basic and thus charged. And so you will not see the hydrophobic polymerization of hemoglobin with this HBC disease, but instead you see crystalline. Now, I've got a couple of images of that I'll go ahead and bring up right now. While we're on the topic, hemoglobin C has a distinct band on electrophoresis. It's not the same band as hemoglobin S. And you can have one S allele and one C allele at the same time. And that would be called hemoglobin SC disease. Now, SC disease is not as poor a prognosis as pure sickle cell disease, which is both of your genes are of the sickle variant. But there are some similarities between the two. As you'll notice in both cases, there is a thorough lack of hemoglobin A, as well as hemoglobin F. Now, here are the crystals that you would see in hemoglobin C disease. So C is for crystals, doesn't get much better than that. There they are, zoom in, look at them real close. They're kind of hexagonal. Here's some more brick-like, block-like, big old things too, you know. And of course, a crystal is just a latticed polymerization, which means that it's the same motif repeated over and over and over again, which is why crystals have geometry. You know, they're not random or sporadic. You know, they're not like snowflakes in that each one looks different. Crystals of a given substance look very similar from crystal to crystal to crystal to crystal, as long as they're made of the same substance, and that's because of the atomic geometry of those molecules. And first aid, what do they have to say about hemoglobin C disease? They just want you to know that it's a little bit more mild disease than pure sickle cell disease. Not as bad. You see crystals. That's about it. Now we get to the good stuff. Pathophysiology of sickle cell disease. It's really two diseases rolled into one. First, you got to worry about the hemolytic anemia, which is usually extravascular, meaning the spleen, macrophages inside the spleen see these sickle cells and they see them get stuck inside the cords of Billroth because they're clumped up and clustered together, and they just yank them out of circulation, phagocytosum, no more sickle cells. And the other component of the disease is, again, the occlusion of small blood vessels leading to tissue ischemia, which can create symptoms such as the ulcer. How do you diagnose the hemolytic anemia? Well, it's normocytic, first and foremost. Number two, the bone marrow is going to be working, should be working, so reticulocyte count should be elevated. And hemoglobin electrophoresis is going to help you make the diagnosis on sickle cell. You'll also see, particularly if it's a chronic, long-standing hemolytic anemia, elevated indirect bilirubinemia. Talking about vaso-occlusion leading to infarction, possible intravascular hemolysis and inflammation. And don't forget, anytime there's infarction, it's a painful process. There is no such thing as a painless infarction unless you're loaded up on something. It's gonna hurt. So when these patients present with the dactylitis, their hands hurt. When they present with the ulcer, that thing hurts. You better give them a shot of lidocaine or something to numb that up while you debride it. It's going to be very, very painful. What do you see on pathology? Well, first of all, EPO is up, erythropoietin. So the bone marrow is hyperplastic, and in sickle cell disease, like in the thalassemias, you might even see this crew cut X-ray of the skull. Let's go take a look at that very quickly. Literally looks like a crew cut. There we go. So what's going on here is red blood cells are growing up through the bone marrow of the skull. And in the skull, you've got these diplo or trabeculae. That's kind of like a cavernous space. And it's just a bunch of cylinders interconnected. And so because it's a bunch of cylinders, red blood cells growing into cylinders, and there's a little bit of calcification there too, you're going to see that. In sickle cell disease, the spleen stops working, period. You get what's called autosplenectomy. So what's a splenectomy? We take the spleen out. So an autosplenectomy is, well, we don't take the spleen out. It's still in your body. It's just did it to itself. It's an autosplenectomy. In early childhood, the spleen starts to get bigger with congestion following several episodes of vaso-occlusion. But over time, the spleen atrophies and shrinks because it's infarcted so much that there's no healthy spleen left. At that point, that's autosplenectomy, and this thing is going to shrink down to the size of your thumb. You're not going to be able to palpate any spleen whatsoever in patients with sickle cell disease, and that's going to be by about the 20th year, this third decade of life. So because the spleen is not working in sickle cell disease, you will see very characteristically these things called Howell-Jolly bodies in red blood cells. And when you see Howell-Jolly bodies, what that means is whatever patient you're looking at is asplenic. Their spleen is either out or it is not functioning. Now, you can also see Howell-Jolly bodies in spherocytosis post-splenectomy, because in a spherocytosis, patients always got an enlarged spleen, and so their anemia is going to persist unless you take the spleen out, because that's what's phagocytosing all the spherocytes. So if you take the spleen out, then there's no more spleen to clean up these Howell-Jolly bodies inside red blood cells. Let me tell you what they are. It's just crud that accumulates. You're living, right? I'm living. And it's like sometimes somebody gives you something that you don't want, but you're not going to throw it away because somebody gave it to you, And so you just put it on a shelf or put it in your closet, put it in a corner. Maybe it's clothes for you. Maybe it's baseball cards. I don't know. Maybe it's whatever. So the gist of it is we all carry around even one or two things that we should throw away, but we don't. Red blood cells are like that too. Except the spleen is really good about making red blood cells throw away everything that they're carrying around that they don't need. So when one of these red blood cells with a Howell-Jolly body gets to the spleen, what happens is the spleen takes it and yanks it out of the circulation, and the red blood cell says, oh God, this is it, I'm about to meet the Lord. And it's like, no, you're fine. We're just going to take this thing out and throw it away, and you just go on your way. Because normally when a red blood cell and a macrophage go off in the macrophage's office to have a talk, that blood cell's not coming back. But in the case of a Howell-Jolly body, sometimes the macrophage just takes a little bite out of the red blood cell. Doesn't eat the whole thing, just takes a little nibble of it. And it'll just let the red blood cell go. So that's why you can also see bite cells sometimes in the blood, is because red blood cells got an inclusion in it and the spleen took a little bite instead of a big bite. So that's the bite cell. Sorry, I don't have a slide for that. Moral of the story, Howell-Jolly bodies, normally the spleen takes care of them. If you don't have a spleen because it's been removed or it's totally non-functional, as in an adult sickle cell disease patient, you're going to see Howell-Jolly bodies on peripheral blood, and that's the only reason why you would ever see the patient's asplenic. Let's talk more about the clinical presentation of sickle cell disease. Asymptomatic until 6 months of age. That's the third time this has come up in this text. The hallmark manifestation of sickle cell disease, the pain crisis, the vaso-occlusive crisis, typically first occurs in early childhood, presenting as dactylitis, in which the hands and feet are swollen, tender, and erythematous. Remember that the spleen in sickle cell disease patients is completely non-functional by about the second year of age. It is going to stop working. And when it does, you're functionally asplenic. That means you're at an increased risk for infection from encapsulated organisms, including strep pneumo, Haemophilus, Neisseria. That's because the spleen has a white pulp containing a lot of B lymphocytes in these periarteriolar lymphatic sheaths, and the B lymphocytes in the lymphoid follicles of this white pulp make a lot of immunoglobulin that can stick to encapsulated bacteria. But if you don't have immunoglobulin, a macrophage, good luck phagocytosing that thing with the capsule on it, because that's the point of the capsule. You can't phagocytose it. So you need lymphocytes in the spleen to check your blood for any pathogens and make some immunoglobulin. And in fact, the most common cause of death in sickle cell disease is sepsis, particularly from strep pneumonia. So if the patient is running out of a spleen very early on in life, you need to get them Pneumovax, the strep pneumonia vaccine, as soon as you can to stop this from occurring. Children with sickle cell disease are also at an increased risk of osteomyelitis. From what? From salmonella. Sketch, got a chicken on one side, a duck on the other, and there's a salmon dinner in the middle, and fish only has its head. It's fish bone. There we go. Salmonella, sickle cell, osteomyelitis. The duck has a sickle. Literally, don't ask me how this duck got this sickle, but it's got it. So there we go. Osteomyelitis, very painful bones. Likes to occur following a cut, right? That would be just the direct contiguous spread, or in the case of salmonella, if it's enteric, gets into your body, goes through your bloodstream, that's a hematogenous osteomyelitis. Transient bacteremia that can infect infarcted bone. So you got to have the bacteremia, but a bone infarction also predisposes you to the osteomyelitis. Now, why in the world would you ever have infarcted bone? Well, maybe it's because your cells are sickling and clumping together and blocking up small capillaries. That's going to predispose you to this osteomyelitis following a bacteremia. Another important bug to watch out for, parvovirus B19, can give you an aplastic crisis, a pure red cell aplasia, meaning only your red blood cells are down, whites and platelets are fine. But when you combine that with sickle cell, can create widespread vaso-occlusion and can wipe out a lot of volume of marrow and can lead to a pancytopenia if it's not managed. So parvo usually goes away on its own. Supportive care is important, but for sickle cell patients, particularly, blood transfusions are going to help them get through this viral episode. We've also got acute splenic sequestration crisis, which we looked at a little bit earlier with the ischemic spleen, characterized by very acute anemia and splenomegaly. Like within half a day's time, this spleen blows up, can present as circulatory collapse because all your blood cells are going to get stuck in the spleen. So there's going to be systemic hypoxia. And hypoxia, remember, is just impaired oxygen delivery, compared to hypoxemia, in which you just don't have any O2 saturation in your blood, right? That's a lung problem typically, or like a methemoglobin, carbon monoxide type thing. So a couple of photos here. Here's osteomyelitis, likes to get into the tibia because it's a pretty big bone, big target. Here it is bilaterally, and some punched out type of lesions. And here it is in the spine on an MRI. So many different bones. Here's an acute chest syndrome. On the left photo here, that's some fluid in the lungs. On the right photo here, right lower lobe, right above the diaphragm there, there's some consolidation. So there's going to be sickling, which blocks up pulmonary capillaries, causing backup of hydrostatic pressure, which is just going to transidatively move out circulation into the interstitium of the lungs. There's your fluid in the lungs. That's acute chest syndrome that you can see in sickle cell disease. Again, it's a vaso-occlusion thing. Go back one more time. Look at this infarcted spleen. There it is on gross. There it is on CT. Should be pretty obvious to you by now how that happens. Talked about acute chest, ischemic stroke, makes a lot of sense. It's a vaso-occlusive disease. And bilirubin, gallstones, brown gallstones made of unconjugated bilirubin, I think. Somebody fact check me. So cholelithiasis also predominant. Again, there's an anemic component and a vaso-occlusive component. So labs, what do you see? You see an anemia, it's normocytic. And if you do a smear, you see Howell-Jolly bodies, indicating the patient is asplenic. You confirm the diagnosis with gel electrophoresis, which separates particles based off size and charge. And this is also how we diagnose thalassemias, because all these different hemoglobins have different shapes, a little bit different charges, so they'll move different distances when you put it in this gel. You can certainly tell the difference between trait and disease based on how much hemoglobin A patient is making. And again, don't forget, if you have hemoglobin CS disease or SC, however you want to spell it, you will also not have any hemoglobin A. Finally, this one drug, hydroxyurea. Does something really interesting. It makes you make fetal hemoglobin, which reduces your risk of sickling. I can't tell you any more about that. So that is sickle cell disease. Again, watch out for the dactylitis. Watch out for the ulcers. Those are the most common manifestations. Also, different target organs can get affected and go downhill very, very quickly because this is a vaso-occlusive problem. Thanks a lot.